Trust. We've taken this grand rounds to celebrate World Sepsis Day, which is on the 13th of September, and that's Sunday. We thought it would be better to get you to come here on Friday rather than on Sunday. We're very kind. So we've got quite an interesting program for you this morning. We're going to sort of set the scene with a patient story from the UK Sepsis Trust, and Julie's story. And Julie Carman is a previous patient with sepsis, who is also part of our steering group. Then Daniel Butterworth, who's right at the front here, is going to talk to us about pre-hospital care for sepsis and how we link up our care within hospital with care before patients come to hospital with paramedics. And then I'm going to sort of unveil what is coming, because we know that the sepsis definitions are going to change. There's a lot of rumors about what it's going to be, so I'm going to just show you what it's likely to be and pretend that I don't know much about it, but I suspect what I'm telling you today is going to be what is going to happen in October when the sepsis definitions change. So without much ado, I'm going to play the video, and then we'll have 5 minutes of discussions after that. So please listen to the video, have a think about what you are going to do differently as you go back to your wards, to your different areas. How is it going to change your practice? How is it going to change your team's practice?
Well, in April 2008, I was knocked from a bike by a speeding driver, so I had a number of injuries. I hit the road with my chin, hence the loss of teeth and broken jaw, and then I hit the road on the side, on the right-hand side, so I have more bruises down that side. So I was in hospital for a while, and my jaw was wired, and then I was sent home. About 6 weeks later, I started to feel very unwell. I got flu-like symptoms. I do work for the NHS, and so I self-medicated, got out the paracetamol and took myself off to bed and rested. But by Monday morning I was feeling much worse, so my husband took me down to the doctor. He rang the orthopaedic department at my local hospital and asked if they'd see me because he felt that I had cellulitis. Probably about 11 by the time we got to A&E, and we went through the system. It was about 3 o'clock by the time it was decided that maybe this wasn't a leg problem because I had recent surgery on my jaw. It was something to do with the Max Fax surgery that I'd had. And Max Fax wasn't done at the particular hospital, so they got in contact with the second hospital and said, please will you see this lady, she's got an infection and we want to rule it out that it's a jaw. So my husband drove me to the other hospital, went in via A&E, was triaged about an hour later. About 7 or 8 o'clock I went up to the dental ward. I was very unwell by this point. I was suffering from what I believe are called rigors. I was shaking a lot, obviously vomiting, and sometimes was very hot and needing to take everything off, and other times was very cold and needed covering up with blankets, and my husband sort of holding me down in this chair. And the orthopaedic surgeon came up about 10 o'clock and agreed the infection was probably in my leg. They couldn't actually find anything in my jaw. A number of the people that I'd seen had said you need IV antibiotics, and once you get those you will start to feel a lot better. But unfortunately nobody actually gave me any antibiotics. They were very kind to me and patted my hand and gave me some paracetamol, but I wasn't given any IV antibiotics. So about midnight we got word that there was a bed, and again it was said, you know, when you get some IV antibiotics you'll start to feel a lot better. At 2 o'clock I was put on a ward. I was given a buzzer to hold, so I pressed the buzzer. A nurse came along and I said, I'm sure I should be having some IV antibiotics. So she went to sister to check and came back and said, you're quite right, but I'm really sorry nobody's written you up for any. The next thing I remember is this argument going on outside in the corridor around somebody needing to prescribe antibiotics. I guess eventually it was because the drips were put and all sorts of things happened. And then I woke up the next morning, seemingly surrounded by doctors. The consultant who was looking after my face was there. There was an orthopaedic surgeon there. There was quite a bit of concern. But I was on IV antibiotics by then. The delay wasn't discussed really, and I think probably because I was, you know, sleeping and dozing off and drifting off, I probably hadn't realised just how time was getting on. Well, I was feeling exhausted, very fragile, Everyone was very kind to me, but I just felt that nobody actually did anything, and a number of people, medical people, said to me, you will start to feel a lot better once you start on IV antibiotics. It was actually 18 hours from when I'd seen my GP in the morning before I actually got any antibiotics, and I'm sure that didn't help my condition. The second hospital, I was seen by the team the following morning, and also Sister came along to see me and introduced herself and kind of apologised for what had happened the night before, and said, she was really sorry, but she said, just to let you know that I have filled in an IR1 report. I thought, oh, well, that's a good thing. The orthopaedic surgeon came back and said, would I like to go back to the first hospital, which was much nearer to home. So about 10 o'clock, I went by ambulance then, and I was taken onto a ward there, and I was on there for a number of days on IV antibiotics, and they were able to remove about 500 mils of pus from my left leg on the first day, and then on the second day it had all filled up again, so they did the same thing. And then I stayed on the ward, this wound was dressed obviously, and given the antibiotics and things for 5 or 6 days, and then I was discharged on IV antibiotics. And I was home for about 3 or 4 days, and then I got this high temperature again and this feeling of sudden hotness and shakiness. Obviously I knew what the problem was, so I asked my husband about 4 o'clock in the afternoon if he would take me back to the hospital that I'd been an inpatient at. We borrowed a wheelchair and he took me up to the ward that I'd been discharged from, where obviously we saw the team that we'd been with the week before. But a very sympathetic sister, an apologetic sister, said, I'm really sorry, but we can't just take you on the ward. You need to be admitted via A&E. I was booked into A&E, and then I was triaged, and eventually I was seen by somebody from orthopaedics. People definitely thought I should be on a ward having some IV antibiotics. Having said that, we'd had another 6-hour delay, so things had probably taken hold again. I was put on a ward, and I was seen by the orthopaedic consultant who said I definitely had severe cellulitis, sepsis, and that I would need an operation to remove some necrotic muscle. So that was organised for the day after, and I do have some numbness down the lower left calf that probably, after all this time, I've been told will probably be permanent. I suppose I expected, within 3 months of the actual injury occurring, that I would have been back at work, back on my bike and fitting well. And we're now almost 3 years down the road, and it's not over yet. I felt let down and ashamed. I was ashamed that I guess the communication systems weren't in place, because that's kind of almost what it was. It was as if everybody knew what was needed doing, and everyone was kind to me, but actually nobody did it. And it made me think afterwards, on reflection, had I been too polite and compliant? I'm not the sort of person to sort of stand up and scream or burst into tears or throw my toys out of the pram, but and surely I don't need to be that sort of person to get treatment. I mean, it also occurred to me when I was ringing for the sister at 2 o'clock in the morning, thinking about it later, had I been a little old lady who hadn't got some NHS experience and able to articulate, I might have just thought, well, they put me in bed now, I'm fine, and maybe rolled over and gone to sleep, maybe not woken up, who knows. In my view, all the complications were linked to the delays. Following on from recovering from this surgery, I was due to have some more surgery on my jaw, and that had to be delayed because I wasn't well enough to have that, so that was delayed for about 6 months. And when I did go back to the max fac surgeon to have what I thought were my implants fitted, my bone had deteriorated and my soft tissue, so I needed to have bone grafts and soft tissue grafts before I could have the implants, and I also needed to have some orthodontic work. So the surgeon said to me, everything's in hand, Julie, don't worry, we've put together a 2-year plan. And I sort of nodded and smiled, and then drove away from my appointment thinking, 2 years, we're already nearly a year into it, I'd expected to be better in a few months, really. within a few weeks of that, I actually had a sort of psychological breakdown. It just seemed to be, one knock too many. I'd been knocked back so many times and I kept coming up, pulling my socks up, getting on with it. I'm not dead, I'm okay. And then it was just like, right, okay, well, another 2 years to go. I'd returned to work. I'd been back at work about 6 months. I just became unable to make a decision, very alert to thinking things were going to happen, having flashbacks. Apparently I was diagnosed with post-traumatic stress, and no one was surprised apart from me really, but I was sort of devastated at that point. Massive cost to the NHS. I was 16 days in hospital extra to what I needed to be. 16 bed days, I know that's a lot. You had lots of treatment, I follow up with GP, district nurses, afterwards months of dressings, months of physio. It was, in my view, it was unnecessary. If the antibiotics could have been given much earlier in the system, on both occasions, I think the outcome would have been much better for me and for the service. It seemed as if everybody thought someone else should be doing it. Everybody knew what should be being done, but everybody assumed that someone else would do that bit. I have been asked, why I didn't make a complaint, and I think because I was so weakened after both episodes in hospital, I just didn't have the energy to do it. I didn't want to go through all the trauma of it. I was worried that one person might get the blame for this, and in my view it definitely wasn't about one person, because the treatment I had was by individuals was good and kind, and I would say that if they were evaluated they would all come out fine, but I kept falling through gaps and I didn't really know or have the strength to make a complaint about the gaps and to be able to articulate that well at the time. I'm hoping by telling my story that people will kind of listen and see behind what happened, and the fact that it happened twice, so it wasn't a one-off. Within 4 or 5 days the same thing was happening again. This might be an opportunity for learning. So although this isn't a complaint, this is my way of saying please listen to this story and think about what's happening at your hospital. Could it happen here? Is it happening here? And if so, what can we do about it?
So quite a powerful video, a patient's story. Julie is remarkable for a number of reasons. First, because she's a sepsis survivor, and she went through all this, and despite going through that level of care and the problems with her care, she decided to devote her time to making a difference in sepsis care. So she used to work for the NHS. She was a pharmacy assistant and also a manager in the NHS when this happened. And now she's a representative. She works with the UK Sepsis Trust, and she's also a member of our sepsis steering group here. She would have loved to be here today but couldn't make it, and she's helping us really with looking at the patient side of improvement in management of sepsis within the trust. So quite a powerful story, and she's doing a lot for our trust. There's time for a few comments or questions about the video. If anybody has any comment they want to make about the video, any comments? Really just to highlight, just reflect on how this affects your practice and really the importance of assessing patients with sepsis quickly, recognizing sepsis, and giving antibiotics in a timely manner within one hour is the target. And that's what she didn't get. Ray?
Reiterate from an emergency department perspective, this isn't a one-off, it's still happening even now. We review cases and it's quite still to see the patient. People are coming down are very, very good at recognising sepsis and diagnosing sepsis, and it is at the forefront of everyone's minds, and everyone is putting down in the notes that things need to be done, things need to be prescribed. They're not actually doing it, and we see that all the time. So what we need to make sure is, once you've decided that something needs to be done, make sure it actually gets done as well.
What the video also highlights is that our focus so far has been on sepsis mortality and reducing mortality. But what Julie highlights in that story is the long-term effects of sepsis. It's not just about saving lives, but the comorbidity associated with sepsis, with post-traumatic stress disorder, chronic fatigue syndrome, anxiety, depression, all linked to sepsis. And as we reduce mortality for sepsis, we've also got to think about how we provide care for the other complications of sepsis that happen long after the patient has left hospital. So let's move on from there, and I have the pleasure to introduce Daniel Butterworth, who's going to talk to us next. He's an advanced paramedic for Northwest Ambulance Services, NWAS, and he's a lead for sepsis for NWAS. He's also a member of our sepsis steering group in the trust, and we're really looking forward to working very closely with NWAS to improve sepsis care. So he's going to talk about pre-hospital care for sepsis and what impact it can have on care for patients within hospital and survival.
Morning, everybody. Thanks very much for the chance to come and speak to you here. My work started initially within NWAS as the sepsis lead and linked that into Advanced Practice Masters. Needed a project to do, and that led me towards sepsis to start off with, which has opened a big can of worms in the pre-hospital world for us, really. So just to gloss over a couple of points at the start off with, we know what most of the facts about sepsis, really, in terms of the loss of life, the cost to the NHS, and the mortality rates that it has. But overall, we just know it's costing the NHS a fortune, and too many people die from it. So within NWAS itself, as you know, with the ambulance service, we've been performance driven based on how quickly we get to patients, the 8-minute target that we've set, and that dominates some of the work, or most of the work that we do. We also have no national guidance pre-hospitally around sepsis, and also there's been, to date, no real education package put in about sepsis. So that's led to us having poor recognition of sepsis pre-hospitally, and consequently delivering poor treatment and poor care to sepsis patients that we've conveyed. So we had to look at how we were going to address that and how we were going to move things forward. So we decided to have a look at, in close working environment with two Manchester hospitals, to have a look at some confirmed sepsis cases that were conveyed by our ambulance resources to their A&E department. So we knew their end diagnosis was a degree of sepsis, either sepsis, severe sepsis, or septic shock, and we could track their journey back through to when they called 999, what they called with, what they presented with when we picked them up, and what we documented, what we treated, and then looked at the hospital care that was provided, and that was for 259 cases to start off with. So we broke some of that care down into some specific metrics that we looked at from an ambulance point of view and what we delivered. So if you look at the second metric down, whether there's a suspicion of sepsis documented on the patient report form and the SIRS criteria fully assessed, was only in about 15% of these cases that had been taken into A&E. So the patients who were diagnosed in A&E and treated with severe sepsis, around 54% received a pre-alert. So from the patient case notes, there's an element we recognised they were sick in 50% of the cases, but didn't specifically attribute it to sepsis. Those severe sepsis patients that received some IV fluid pre-hospital was around 20%. And what we created at the bottom, looking at the standards of care we wanted to roll out across NWAS, we created a little care bundle that involved the patients receiving some fluid, receiving oxygen if they're indicated, providing a pre-hospital pre-alert, and documenting that suspicion of sepsis on the patient report form. And that happened in about 10% of cases. So it highlighted to us straight away we've got a large amount of work to do within the ambulance service. We tried to launch something as early as March 2014, but the main driver for change was the NHS Stage 2 patient safety alert that then said all ambulance services must be undertaking work towards screening tools, education package, and advancing care, basically, because it was recognised we have a role to play in improving sepsis care across the NHS, really. So from September 2014, it picked up pace. So within the ambulance service, we've recognised the government is the biggest driver of change, really, for us, because we have to try and move away from our performance criteria of the 8-minute response time and keep the patient-centred focus, really. So, looking at those 259 cases, we had an aim to utilise some screening tools that were in existence, used in hospital generally, and compare retrospectively how well they would have identified those patients that we'd conveyed to hospital. We then wanted to develop our own or use those tools to formulate the basis of an MWAS screening tool, and then we wanted to pilot that screening tool with an education package and be able to track that patient's journey that we thought was septic through to their end diagnosis again at hospital, and also see if what we were doing had an impact on the hospital's performance within treating sepsis as well. So in the retrospective analysis, we looked at two screening tools. So your one on the left, the Robson tool, is more of a typical in-hospital type screening tool that uses systolic blood pressure, mean arterial pressure, SAPs, not past urine, prolonged bleeding, and involves lactate for identifying the severe sepsis. Obviously, pre-hospital at the moment, we don't generally have point-of-care lactate testing, so that eliminated the lactate reading out as one of the markers for severe sepsis. And on the right, there's the UK Sepsis Trust red flag screening tool, which we were going to apply pre-hospitally and see how that identified. So we found that the screening tools generally, the one on the left, the Robson hospital-based tool was 93% it picked up in terms of overall sepsis and 89% for the red flag trust data. The main difference occurred when we were looking at the severe sepsis septic shock cases, in that 42% were picked up with the sort of Robson tool, whereas the red flag picked up around 90% of the severe sepsis cases. But on the flip side of that, it would also potentially pose as a problem in the false positives. False positives being the sepsis patient that's diagnosed at hospital, the screening tools would say they were severe sepsis or septic shock pre-hospitally in sort of a false manner, really. So the Robson hospital-based screening tool performed better in that measure, 18% false positives, compared to the red flag that had a lot of patients that were diagnosed with sepsis. It put them into the red flag severe sepsis criteria bundle pre-hospitally. So there was concerns raised by the hospitals based on this data that they were worried about the number of pre-alerts that were going to come in and the number of patients that were going to start potentially getting large boluses of fluid and high flow oxygen, whether that was actually indicated at the time or not. So I broke down what were those false positives in the red flag screening tool, why was it so high? And we found the respiratory rate of greater than 25 in 67% of the occasions was the reason why there was this false positive trigger. So we sat down and discussed that in liaison with the hospital, and we decided we were going to move to have a look at if we had a respiratory rate of greater than 30, would that make a difference? Okay, so we applied the same data on the same data set again and found that the respiratory rate, the overall identification of severe sepsis dropped by 3% using a respiratory rate of 30 compared to 25, but it reduced the false positives from 40 down to 24. So the decision was made, that was what we were going to run with, the respiratory rate of 30. We were bearing in mind a lot of people in the pre-hospital field, patients that we pick up, have that extra degree of anxiety because they've phoned in a crisis. So they automatically may have a raised respiratory rate on top of respiratory-based disease, on top of infection, sepsis-based criteria. So we just felt we were going to run with the 30 initially now. So that was the screening tool that we put together based on the red flag concept. So your simple infection at the start, based on 2 or more SIRS criteria, and then one of the following red flags, which would elicit then 2 treatment pathways, either a sepsis treatment pathway or a red flag possible severe sepsis treatment pathway for us to follow pre-hospitally. A bit more difficult to read, sorry, but then, so we'd have the 2 different treatment pathways. The first change for us pre-hospital was we were going to convey any patients showing signs of sepsis to hospital. Now, prior to this project, there's times where we would be referring some patients who are generally fit and well to primary care, but the decision was made we were going to bring everybody into hospital during this pilot. The key thing being we wanted to ensure that suspicion of sepsis was documented on the patient report form. Some of the research coming out of America was showing if just sepsis being documented on an ambulance patient report form significantly increased the sepsis bundle compliance within hospital. Verbally confirming that suspicion of sepsis at triage, using that term sepsis. A lot of the cases we looked at suspected infections, but it's getting used to using that common terminology between different healthcare professionals using that term of sepsis. And what we also trialled that's built into the project and not fully evaluated yet was a sepsis screening tool form. So it was carried by the ambulance paramedics. They would fill in a form that was a 2-part form that was then halved. So when you got to hospital, half the screening tool form stayed with us, half went on the patient journey then. It was scanned onto the documents but stayed with the patient through their journey in A&E, so that it constantly flagged when that the patient had identified markers of sepsis, what time and what treatment had been provided, and that stayed with them in their journey through A&E. So the hospitals are evaluating at the moment the difference between, if there's a difference between the patients we brought in using that tool and use that form compared to the ones that didn't, to see if that does make a difference, having a specific document that travels through the A&E with them. And then the difference in terms of treatment for the red flag sepsis, we were looking at what elements of sepsis 6 care we could deliver safely. Again, oxygen therapy, IV access, and we were going to give 250 ml bolus of fluid, followed by a second bolus of fluid if still indicated, knowing that a lot of severe sepsis patients needed more than that, but focus on we need to get these patients to hospital rather than staying and playing on scene where you can get the definitive care and what they need in hospital. And then there would be what we call an amber pre-alert to A&E, letting them know this sepsis patient's en route in with the possible red flag sepsis. So what happened was we launched a 2-hour training package for around 120 staff in central Manchester that came in and completed the sepsis training package, and then they went out into practice, applied the screening tool and filled these forms in when they used it, and they were collected at hospital, so we knew when these forms had been used and we can track that patient journey. So we found in terms of the difference, this was done now on over 120 patients we've treated using this screening tool and evaluated, and we found that suspicion of sepsis and whether the SIRS was fully documented had risen from 15% to 94%. Pre-alerts for severe sepsis cases that were diagnosed, so we know the end diagnosis in these patients at hospital was 98%. The amount of fluids that were given went up significantly, and that care bundle at the end, whether they had the suspicion of sepsis raised, pre-alert, oxygen and fluids given, rose from 10% to 90%, so a significant improvement really, which is shown on the graph there for all the metrics we've followed through. So that indicated to us from this pilot study, this is something we need to try and advance and move forward across the northwest really, as a matter of urgency. Some research from Gray found that they suggested 88% of all patients presenting with sepsis at A&E arrive via ambulance, which says we've got pre-hospital, we've got a chance to start that sepsis pathway rolling early on in terms of identification and good communication and handover to clinicians at hospital. In our pilot study, we found around 73% of all sepsis cases in A&E were conveyed by ambulance, so slightly less, but significant nonetheless. And one of the interesting stats we found was if patients received a pre-alert and or had IV access gains, then the sepsis 6 compliance in hospital rose from 18% to 40%. So we know there's evidence there that says that what we do pre-hospital can, with the good communication and what we've identified, affect what happens to the patients within A&E. The next step obviously is coming to speak to people to raise the awareness around what we're doing within the North West Ambulance Service. We've also got to look at, we know sensitivity-wise how well the red flag concept works pre-hospitally now. Well, we're just waiting for the final end diagnosis of a few patients so that we can see how specific it is and link that back to the UK Sepsis Trust, because their red flag concept doesn't really have any end patient diagnosis evidence to it. They felt, discussing it with them, they needed to launch something, but they've not necessarily got a huge evidence base behind it. So we're hoping to provide some evidence that if you follow the red flag concept pre-hospital, it will actually, what level it determines a patient has got sepsis or severe sepsis. There's a point of care lactate bid gone in, so we're going to pilot having pre-hospital point of care lactate machines within central Manchester to start off with, to build that into the screening tool. And also we're looking at a health foundation bid to help fund the rollout of this across MWAS really. So I was saying earlier on, pre-hospitally nationally has no national policy going on or protocol at the moment. So I'm involved in writing that nationally as well, and at the moment that's based on going down the red flag concept as well nationally. But of course with the definitions, that Emmanuel's going to talk about in the next presentation, changing in October, everything's just been put on hold until we find out what those definitions are going to be and how that will affect the work that's going on and has been done more recently. Any questions on that? Thanks for the time.
Any questions from the floor? I think we've got roughly 10 minutes for questions, so if there are any questions from the floor, while you're gathering your thoughts, Daniel, that's quite powerful data you've shown there, especially your data retrospectively and prospectively in Manchester after introducing the sepsis screening tool and bundle. One of the aspects which how you haven't mentioned there is the role of antibiotics, pre-hospital antibiotics. Do you want to say a word about what is the potential role or what the evidence is for antibiotics before hospital?
Yeah, so at the moment with an MWAS, the only antibiotic we carry broad spectrum wise is benzyl penicillin, and our issue is going to be having cultures taken before giving the broad spectrum antibiotic. So we know from research that's come out that if you give the broad spectrum antibiotic without taking the cultures first, then actually some of the outcomes in severe sepsis can be worse. So we've held off the antibiotics to start off with, but there is a national study that's been formulated and has been granted funding to look at pre-hospital antibiotics, of which MWAS has been asked to be one of the pilot sites. If you know the Fantasi trial that's going on in Amsterdam pre-hospitally, the boundary or the barrier you've got to get across is the cultures and the culture bottles. So I know in Amsterdam, for example, they've carried 5 different types of culture bottles depending on which hospital they're going to go to. So there's going to be a lot of logistical problems within Manchester, for example. I know we've got 13, 14 hospitals. That would be 6 types of culture bottles we've looked into. So there's significant barriers to come across, but there is the driver and recognition that it is the early antibiotics that we can start pre-hospitally. But in this initial phase of the pilot, we wanted to focus on the recognition of sepsis and trying to work on that communication between pre-hospital clinicians and then clinicians in hospital to see and look at what work we can do around those barriers that exist there.
Any questions?
Are you able to comment on the success the ambulance services had in a 12-month period getting brilliant compliance compared to the struggle we're still having within the trust over more than 5 years? And it's linking to Julie's story so people are aware of it. What is going to make the difference to leaping forward with successful compliance within the trust?
So just to be clear what the question is, you've seen the data from the ambulance service and the improvement that they've had with the prospective data with introducing a tool and how recognition of sepsis and pre-hospital alert has made a difference, and also the bundle, compliance with the bundle, which is IV access with fluids, has made so it managed to do that quite quickly. I think there are a number of reasons for that. I mean, certainly within the trust, I think everybody will recognize that we are quite a long way away from where we were a year ago, where previous audits in the trust show that 17% of patients with severe sepsis, septic shock, received the sepsis 6 within 6 hours. And now we're far away from that. Our data suggests that it's more around now, within 4 hours, around 60% of patients with severe sepsis, septic shock receiving their sepsis 6 bundle within 4 hours. So we're far away from that. Our data is not that different from other trusts. I think the reason for the speed of improvement in the ambulance service compared to ourselves is also linked with the number of staff and complexity of the organization. So we've had much more staff, and the care that we provide is much more people involved and much more complex. But what we have to do is we're focused on systems. Education is part of it, but there've been a number of significant changes in our systems of care for patients with sepsis. And going forward in the next year, there's also going to be quite significant changes. For example, what the next step is to introduce a sepsis team in accident emergency and MAU, which will be a nurse-led team similar to the stroke team. So when patients arrive in the hospital, they're fast-tracked to care with severe sepsis and septic shock. They're fast-tracked to care and receive their bundle within 1 hour. And I think that's going to be something that's going to have a significant impact on the way care is delivered at the front door and we'll also have to look at care within the hospital for patients with sepsis.
Yeah, just to interject on that, from an NWAS point of view, we've probably got a significant bank of clinicians that have been frustrated at lack of clinical advancement to do with sepsis and focus on our other performance targets. So when we've actually come to talk about this and offer education around this, there's been a real drive to want to take that up, and the 120 staff we trained initially all came in their own time, came for 2 hours and did the training in their own time. So we appreciate the figures may be skewed slightly in that they were clinicians that really wanted to take that education on board, and it wasn't from a mandatory point of view, and it's something new within the trust as opposed to they've seen hospital care talking about this for the last 10 years and how they can improve it, and had that frustration that nothing's happened pre-hospital to that point, really.
Any other questions?
I just want to ask, you know, the delay between with the administration of antibiotic, is it the delay in administration, a delay in prescribing, delay, you know, what is the biggest hurdle towards administration of antibiotic or transfer to the ward, you know, is that what causing the delay?
So Huda's question is what causes the delay in administration of antibiotics and where are the delays? It's a very good question, very complex question. It seems quite easy, isn't it, to just prescribe antibiotics and you should be able to give it. Julie's story highlights that. It took her 18 hours from when she was referred by her GP to her getting antibiotics. And despite people saying you need antibiotics, it didn't happen. And you see that happening in the trust, don't we? But we've looked at we've process mapped the process of administration of antibiotics. And there are so many different reasons why it may not happen. First is what you said at the beginning. It's prescribed, but a nurse isn't told that it's prescribed. So it may be on a drug chart and put by the side of the patient, and that is where it may break up, fall down. So there are a lot of human factors that contribute to that. It may be that they're prescribed, a nurse is told, but they forget because they're busy. There's another sick patient, they run to that patient. It may be because they don't understand how significant it is to give antibiotics within 1 hour, hence why we're doing all the education. Another barrier is where the antibiotic is, and they need to make the infusion of antibiotic and the length to need to get IV access, and not everybody is trained to get IV access. So it may be prescribed, it's there, but there's nobody who can administer, who can put a line in because the house officer is busy, the nurses can't do it, so antibiotic doesn't get in. There may be a line in there, but it needs to be given by infusion, so you need to prepare the infusion and it takes time. So an example of things that we're trying to do to address that is we've done a pilot on MAU and emergency department of bolus administration of some antibiotics, where you don't, to reduce the barrier of having to prepare an infusion, because that was brought up by nursing staff and doctors as one of the reasons for slowing them down. So for some antibiotics that can be given as a bolus, we've piloted giving them as a bolus. And what we found so far is that there is some evidence from our pilot that giving those antibiotics as a bolus seems to improve the time to administration of antibiotics. So we're going to review that pilot and decide on how we proceed within the trust with that data. So it's quite complex. There are a lot of human factors involved, and what we need to do is work on all those human factors to speed up time to administration of antibiotics. So if there are no more questions, thank you very much. So what I'm going to do next is talk to you about what is coming, and it's quite, I think, quite linked to what Daniel was saying about definition of sepsis and problems with sensitivity and specificity of the definition of sepsis. So I'm going to give you a preview of what is coming after October in terms of how sepsis may be defined, because there's a big drive now to change the definition for sepsis. There's a big disclaimer in that this is second-hand information. I wasn't involved in designing the measures, the definition. It may change, but the principles, I think, are correct. And don't go and quote me elsewhere that I'm the person who told you these are going to be the definition for sepsis. But I'm sure the principles will be right. So this is the definition we have for sepsis at the moment. That it's a continuum of illness, starting from sepsis to severe sepsis and then septic shock. This first definition was set up in 1991 by an international task force defining sepsis based on the presence of infection and SIRS criteria, at least 2 SIRS criteria: high respiratory rate, high temperature, high pulse, or a high white cell count or low white cell count. And if they have at least 2 of these with suspected infection, then defined as sepsis. And the reason for that was to try and differentiate patients with infection from patients with sepsis, and also help to get patients recruited into trials for sepsis. But you can see quite straight away the problems which Daniel has already highlighted with that definition, in that people without infection will easily trigger on the SIRS criteria. And so specificity is a problem. You also find that patients with infection, for example, flu, may trigger on the SIRS criteria. So how do you differentiate patients then with infection from patients with sepsis? And is sepsis and infection, are they the same thing? And that's one issue. So specificity is a problem with this definition. Now, the definition of severe sepsis is a patient with sepsis with organ dysfunction of any sort, be it cardiovascular, renal, neurological, respiratory, whatever organ dysfunction the patient has, then that's by definition severe sepsis. Now, these definitions have not changed over 20 years since they were set up in 1991. There's a recent study from the published in the New England Journal of Medicine, and a study done in New Zealand and Australia, where they looked at patients with infection in intensive care. So these are patients with organ dysfunction because they're clearly very sick in intensive care, and looked at what percentage of those patients actually triggered based on the SIRS criteria. And what they found was that 1 in 8 patients, 12% of patients, did not have SIRS criteria, did not meet the SIRS criteria. And these are patients with infection and in intensive care, so very sick, with organ dysfunction clearly because they're intensive care, 12% not triggering on the SIRS criteria. So the sensitivity of these criteria to define severe sepsis is also in question. So we've got problems with specificity, we've got problems with sensitivity. And septic shock is sort of defined as a patient with severe sepsis who's hypotensive, and despite adequate fluid resuscitation, they remain hypotensive or have a persistently raised lactate. And there lies another problem with the definition, in that adequate fluid resuscitation is not clearly defined. The blood pressure, people sometimes use a blood pressure of less than 90, others a blood pressure of less than 100. Raised lactate is also, some people use a lactate of greater than 2, some are greater than 4. And so the problem with the definition, there have been problems with definition of shock. And so different types of patients have entered into different trials for severe sepsis and septic shock. So it's not surprising that some of the mortality reduction seen in trials has been different because there have been different patients that have been entered into these trials with different definitions for shock. You also recognize the fact that when I say sepsis, what do you think I'm referring to? Am I referring to uncomplicated sepsis when I say sepsis? Am I referring to all sepsis, the whole continuum, sepsis, severe sepsis, septic shock? Or when I say sepsis, am I referring to severe sepsis? And all people use use sepsis to mean different things. They say sepsis to mean this, they say sepsis to mean all of it, they say sepsis to mean severe sepsis or septic shock. And that is also a problem. The other issue is clinicians. We know from the SIRS criteria, because they are not very specific, that clinicians are not very good tools for a clinician to use to make a diagnosis. And so it's not surprising that even senior clinicians tend to miss diagnosis of sepsis because of those criteria. So all these are potential issues with the definition of sepsis as it stands. The other issue is members of the public. So how do you explain this then to a member of the public if it's so complex for healthcare workers? And how many patients leave hospital knowing that they've had a diagnosis of sepsis? And how do you define that for a patient? Sepsis here? Have they had severe sepsis? Have they had septic shock? So the public understanding of sepsis is also quite convoluted and difficult because of how complex the definition is. And that's one of the drivers for improving the definition of sepsis. So, and this is what it results in. that coding and data about number of cases of sepsis is very difficult to understand. And when you count it, it's very difficult to know exactly what you're counting. So if you look at the northwest of England, for example, and look at data for sepsis within the different hospitals in the northwest, we have one of the highest numbers of cases of sepsis because we probably record a large number of cases of people with sepsis rather than severe sepsis and septic shock. Other hospitals will report just patients with septic shock or severe sepsis. They have a lower number of cases of sepsis. And so when you're looking at trends in incidence and trends in outcomes of patients within a region or national or internationally, it's very difficult to compare because they're recording different things, because they're coding different things. And that is another reason why they had to look really at the definition of sepsis. So what do we want as an ideal definition for sepsis? We want something which the clinicians can use reliably to identify patients who are likely to deteriorate and therefore need rapid care, where that can use that to identify patients that are the sickest and that need to intervene quickly. And also it can help coding so that we can have a better understanding of incidence of sepsis, a better understanding of outcomes for the intervention that we're using to try and improve sepsis. And this is what a task force which was set up in January last year set as objective, to improve the diagnosis of sepsis, the definition of sepsis, by addressing all these issues. So it was this task force that was set up by the European Society of Intensive Care Medicine and the Society of Critical Care Medicine. Now, some of you would have come across the SOFA score, Sequential Organ Failure Assessment Score. It used to be called the Sepsis-Related Organ Failure Assessment Score. The SOFA score, it's a mortality prognostic score used in critical care quite frequently. How many people here have come across this score, SOFA score? Not many, a few people. But this is used quite frequently in critical care. It is quite highly validated as a prognostic score for patients with sepsis. Patients who are ill anyway, but it's also well validated in sepsis, and it's probably the most validated prognostic score for patients with sepsis. So it uses 6 elements of organ dysfunction in sepsis, be it neurological with GCS score, and as the GCS score falls, your score gets higher. Respiratory dysfunction, as evidenced by a ratio of the PaO2 or FiO2 on the blood gas over FiO2 on the blood gas, and the lower it is, the more severely ill the patient is. And then it uses blood pressure, and it uses mean arterial blood pressure, which is not something we measure on a routine basis on the wards, do we? But it's what it uses, mean arterial blood pressure. And the lower the mean arterial blood pressure, or the use of inotropes, of vasopressors, then the score also is higher. Renal dysfunction as measured by creatinine, and as it rises, the score is higher. Liver dysfunction measured by your bilirubin, the higher it is as well, the higher the score. And then hematological dysfunction with your platelet count. As your platelet count falls, the score higher. And so you give your patient a score based on an assessment of these 6 organs, key organs, and then you come up with a total SOFA score. And there is, as I said, a lot of data to suggest that as the SOFA score rises, mortality also rises. And as SOFA score changes, mortality also changes. And this is one of the studies that looked at that for patients with sepsis, again showing quite a steep and steady rise in mortality as your SOFA score goes up. So it's a validated tool, but used predominantly in critical care. So the first proposal, which is coming up as a definition for sepsis, is that sepsis should be defined as a patient with infection plus a SOFA score of greater than or equals to 2, because that equates to a significantly higher mortality, 10% increase in mortality compared to other hospital patients with infection without sepsis. So the first proposal that is now being used is that we should use infection plus a SOFA score of greater than or equal to 2 to define a patient with sepsis. Now, I told you about the problems with definition for septic shock. What we need with a definition of septic shock is a definition that differentiates sepsis from septic shock in terms of mortality. the outcomes being significantly higher in patients, the outcomes being significantly poorer in patients with septic shock. So we need a definition which demonstrates, highlights the fact that septic shock is more severe than sepsis itself. And the definition which is being proposed is that you have a mean arterial pressure of less than 65, and you're not improving despite fluid resuscitation, vasopressors, and you have a lactate of greater than 2. And they've used this definition and tried to validate it with retrospective data from America and other parts of the world. They have databases from the Surviving Sepsis campaign that they've used, and they've interrogated those databases using this to try and see what the outcomes are for patients that have this definition. And mortality for patients with this definition is around 50%, while mortality for patients who have only a low blood pressure on vasopressors is around 30%. For those that have a low blood pressure with a raised lactate is also around 30%. So combining them brings together a group of patients with significantly higher mortality than patients who have sepsis with just a low blood pressure with vasopressors or just a high lactate. So the definition proposed for septic shock is mean arterial pressure low, you are on vasopressors after fluid resuscitation, and you still have a lactate of greater than 2. That's what's being proposed. Now, what is also being proposed, as you realize that as the SKU, that definition it's very critical care, intensive care focused. And on the wards, in the ambulance service, in MAU, ED, we also need a tool that is going to help to identify patients at the bedside before you get their U&Es back, before you get their full blood count back. And so what they've also done is interrogated databases to try and use logistic regression to find what indicators, what criteria, markers, clinical markers are associated with higher mortality or longer stay in intensive care. And based on logistic regression, what they found was that a low GCS, a raised respiratory rate of more than 22 or equal to 22, and a blood pressure less than or equal to 100 seem to be the main indicators of poor outcome in patients with sepsis. So what they're proposing is that at the bedside, staff use a Q-SOFA, a quick SOFA score, to identify patients who are likely to do badly, and then go on then to screen for sepsis, investigate for sepsis, initiate treatment, or refer to critical care. So there'll be SOFA, then there'll be a quick SOFA. Now, I've already raised some issues about potential problems with that. You can see why it's being done. It's mainly being driven by intensive care. It's quite intensive care focus. We already have difficulties filling in or documenting CURB score, or doing CURB 65 score for 5 simple criteria for pneumonia. Those SOFA scores with 6 items, 6 organ dysfunction, and 4 levels of complexity, which are challenging if you can ever remember those cutoffs, will make it very difficult for people to actually use at the bedside of the patient in ED and MAU. So that is, I think, a potential problem. We don't, at the moment, we have surviving sepsis data, surviving sepsis campaign data, which has shown that patients, that by using the old definitions, with quality improvement, early identification and resuscitation of patients with sepsis, mortality of sepsis has come down. But we don't yet have prospective data that this works, and we don't have any quality improvement data that this works. All this is based on modeling using retrospective data. And lactate, which in most other trials has been associated with significant reduction in high lactate associated with significant reduction in mortality, doesn't really feature in the definition of sepsis apart from septic shock, and it's with a low blood pressure and vasopressors. So it really goes against a lot of the data that's available for lactate. So just to summarize what may be coming is that sepsis will then be defined as a life-threatening organ dysfunction due to a dysregulation and abnormal immune response to infection. So life-threatening organ dysfunction, and that's how it's likely to be defined. And it's likely that severe sepsis may no longer be used, and all you have is sepsis. And when you use the word sepsis, you mean there is severe life-threatening organ dysfunction. and they would probably scrap sepsis definition. And so you just have sepsis, infection, sepsis, septic shock, as defined by what I've just said. And which means when you do say the word sepsis, you expect that you automatically think about critical care, because by definition they already have significant organ dysfunction. So my take on what's going to happen is that sepsis is probably going to then be defined mean really sick infection, somebody who has infection but is really sick and needing critical care, with organ dysfunction and needing critical care. And I think the tool we're going to use at the bedside of the patient is like to be what's called a Q-SOFA, with those 3 criteria. And then we're going to have to find a way of also using the complex SOFA score if it doesn't get simplified through consultation and refining of the definition. So I think I'm going to stop there and take any questions, but that is a feel of what is coming in terms of definition of sepsis. And once it's defined in a few months' time, we're going to have to respond to it and see how we change our practice to address that. Any questions?
The new definitions are obviously diagnosed with really sick patients and will improve the care that they receive. Has there been any work done on the patients that are going to be missed with the new scoring system? Because obviously we throw a very wide net, and I appreciate we treat probably people more aggressively than necessary sometimes, but that means that at least the ones that need the correct treatment are getting it at the right time. The new scoring system will miss those patients. And I've got concerns there.
That is one of the concerns which I also have, in that the intermediate patients may be missed, especially patients with infection, raised lactate, who will also do badly, who don't fit within this definition. So somehow I think in implementing this, if it's this, we're going to have to think about how we still provide rapid care for those patients, because otherwise we'll be focusing just on the people at the tip of the iceberg. And as I said, this is highly driven, although in ID physicians, respiratory physicians, surgeons are also involved in this, defining this, it's highly driven by intensive care. Any other questions? So no other questions. So I think on that note, I'll leave you to reflect on what is coming in terms of sepsis care, and thank you all for coming today. Thank you. Sorry, just to add that there's a sepsis stall for World Sepsis Day at the front of the hospital, so please visit it. There are a lot of things to take home, pens, all that type of thing. Please visit the sepsis stall.